Thank you everyone for being here. It's really actually been nice to see everyone trickle in and see us all represent what we're so passionate about. And for me tonight, I want to talk about pediatric cochlear implants and talk about some of the updates, the challenges, and the barriers. And we usually have a pretty diverse group of faculty and members of our department at these grand rounds. And the way I selected what I wanted to talk about was thinking about the audience. And we have residents and fellows, we have trainees, we have our faculty who are in otology, whether it's adult or pediatric, some of our faculty who never really look in ears, our audiologists. And so I want everyone to walk away with something new and to really know that this is what's the most recent evidence in pediatric cochlear implantation. And then I have some information for the residents, and that is talking about some of the historical assumptions in cochlear implant surgery, which can be applied to adult and pediatric implant surgery, and talking about whether that still stands or if there's new evidence that should make us think again about how we're managing our patients. So the outline of the talk, this is a very big topic, as you can imagine. And even one section of this can be covered in an entire hour. So I really selected things that I thought had new updates that I could share with you guys, and also talk about challenges and barriers so that we can understand our patients and we can bring them better care. So we'll briefly talk about pediatric hearing loss. We'll talk about cochlear implant outcomes and questions that some of the trainees may always have, as in different types of electrodes and different types of approaches and what is better. The things that us otologists enjoy thinking about. We'll talk about single-sided deafness. What is the recent literature and practice? Where are we going in this area? Some surgical controversies. I would like to also bring up some of our special pediatric populations, the children that have more than just hearing loss as a disability. And then there'll be a common theme of barriers to care that I want you to think about so that we can, again, give our patients the best possible care and give compassionate care. And lastly, I'll end with bringing this all together and talking about how this relates to our well-being. So hearing loss is the most common birth defect. And I put this chart up to show you that even if you're not a pediatric otologist or a pediatric otolaryngologist, you will encounter pediatric hearing loss in your life. You probably have patients or know people that have Down syndrome or cleft lip or palate, and you can see that hearing loss in infants is much more common than that. So this is something that it's not just something that I'm passionate about. This is something that we all need to have up-to-date knowledge on. And so the barriers to care for these infants, well, there's hundreds of hospitals that are not screening for hearing loss, unfortunately. Many babies are discharged from the hospital and they have not been appropriately screened. And this even happens at tertiary care centers like our own. Imagine a patient who's born premature, has complex medical history, has a lot of studies and tests and a lot of follow-up arranged. Hearing screening can be something that's sort of falls off the radar when they've been in the hospital for 9 months, a year. Another issue is that the legislation is variable state by state, and so this can create a little bit of asymmetry. And then follow-up rates are low. So when babies are born at tertiary care centers like our own, they may not be from here, they may be from Central California, and then to be able to set up follow-up, whether it's locally or here, there's that gap in communication. So the legislative mandates vary by state. This is just to show you that there isn't one way that each state does it, kind of like how COVID has been managed. Every state is different. And again, when you have that, you have gaps in how things are being handled at a national level. Briefly, we'll talk about pediatric hearing loss. And this slide is just to show that there's a lot of different causes. I'm not going to go into any of these again, because that's a lot of detail and we have a set amount of time and a set number of goals today. But incidence at birth of hearing loss is almost 70% genetic. And when diagnosed at a toddler age, it's less so. And there are other diagnoses that come up. And that is the purpose of this slide. There are lots of etiologies, including genetic, infectious, environmental, um, and so something to think about. Pediatric hearing loss. So 15,000 children have some form of hearing loss. 1 or 2 in a 1,000 have severe to profound hearing loss. So that impact is something when you really think, you have to really think about this. How is this impacting my patient? Now, sound aware, just the basic sound awareness, we're not even talking about speech and language yet, relates to just safety. For example, a toddler who just learned to ride their bike now can't hear an oncoming car. Speech and language is a big component of hearing loss because our patients in that category, the 1 to 1,000 children that have severe to profound hearing loss, if not implanted or amplified appropriately, will not develop speech and language. This has big educational implications, as you can imagine. There are educational setups for these children. Our patients that have some form of hearing loss might not be in that setup. They are in a traditional classroom, and that poses a lot of challenges to their ability to learn. And then one that I didn't think about, but perhaps many of you who treat adults can think about this, the future opportunities, employment, salary, earning potential to advance in whatever your career or craft is limited in these patients that have hearing loss, whether it's severe or mild. And so it has this lifelong impact, you know, emotionally, educationally, financially. And the bottom line is the cost per child when untreated is about $1 million. And I want to mention that because we think so much about when we're trying to decide or trying to recommend cochlear implantation, we think so much about this is an expensive device, expensive surgery, there's follow-up, there's a mapping, there's frequent appointments with audiology. But look at the cost, and this is just what you can measure. There's so much more that you cannot measure when hearing loss is left untreated. And the problem is that only 36% of infants that need implants receive them. So there's a barrier there. There's more than 60% of patients that need a cochlear implant, pediatric patients that are not receiving them. So let's take a moment to talk about, well, what are these barriers to care so that we can treat our patients effectively. We can help identify who might be at risk, who may need more surveillance or more assistance in terms of, you know, getting the correct evaluation, getting the correct workup, timely workup. And so this is a paper that is out of Kentucky where they have a group that studies barriers in cochlear implantation. I thought this was very interesting because I have a significant number of patients that are delayed identification, a lot from Central California. I know some of the audiologists might be smiling right now. Many patients that have what we read, you know, in their referral is progressive hearing loss, and now they're 2 or 2.5, and they have no hearing and no language. And so it's important to think about, well, what sort of barriers did this patient have that led them to become in this category of delayed implantation and delayed identification? Because we know implantation after age 2 has, the outcomes are not as good as earlier implantation. And I'll talk a little bit more about that in a minute. So if you live rurally, if you drive more than an hour to come to visits to get care for your hearing loss, for cochlear implantation, if that's the closest center, you're at higher risk. Parental education was also an issue. So they looked at maternal education, and they also looked at insurance status, which makes sense. So these are the things that we should be thinking about as clinicians as to what could cause our patients to have delayed care and how we can improve their timely care. This is also, again, applicable in my practice because I have patients that are living far away. So if you imagine an infant who we have the clock is ticking in terms of getting good outcomes, and timing matters. If they reschedule a visit and they're driving 4 hours in, and now they have to reschedule a CT scan and an MRI and a visit with you, and then it's 8 weeks out now, that's just more time that child is losing, and we know we're getting worse outcomes. So talking about timely implantation, the recent update that we all should be aware of is the FDA approving the age of implantation to now 9 months, specifically for cochlear devices. And so this is important because prior to this, the previous age for FDA approval was 12 months. And we had been practicing off-label and implanting children earlier than that because we had substantial evidence that they had better speech and language outcomes. Now it's FDA approved. And in fact, there are groups implanting even younger than 9 months at our institution as well. So why are we doing this? Well, cochlear implants provide auditory awareness, speech understanding, sound clarity, language skills. And I will go through some of this in more detail in the further portion of the talk where we talk about SSD. But the quality of life improvement and the educational outcomes is what has overwhelmingly pushed the FDA to approve at 9 months. But I think one of the key pieces of data was that 80% of children who received a cochlear implant when they were younger than 1 year old, they, in a longitudinal study looking at speech and language ability, they had better receptive vocabulary knowledge. They were essentially on the same trajectory as their hearing peers by the time they were ready to enter school, which I think is remarkable. And again, which is one of the reasons why this age was updated to 9 months. So when we talk about implanting children, we also talk about implanting very young children. It's a different approach than adult cochlear implants. And here are some of the things to think about. And we'll talk a little bit more about this, but this is a little bit of an overview. It's important to have a proficient pediatric anesthesia team like we do here at Stanford that can manage a young infant hemodynamically, airway, through a surgery that could be lengthy, if bilateral, could be several hours. There are specific surgical considerations to take into account in infants, such as the skull anatomy and the incision. Any of the residents that have ever done a cochlear implant with me know that I'm very particular, and we all are, about where our incision goes and using 15-blade cold steel inferiorly because they do not have a well-developed mastoid tip. So you can hurt the facial nerve if you use cautery inferiorly for the residents. We want to minimize blood loss, and this is actually even more important in the very young infants because a little bit of blood loss in a routine cochlear implant surgery can seem pretty normal, but the younger the infant, the more that blood is a higher percentage of their entire body's blood volume, their EBL. So it's important to be very conscientious and use certain types of dissection planes that are avascular. Your access is really important. So you want to use as much, you don't have that much space, but you need to use it very efficiently. You need to understand your anatomy very well. And so you want to use all the area that you can access, which means having an adequate mastoidectomy and a very nicely open facial recess. Your recess may be smaller, so you may be having less space there, but knowing where your anatomy is and being confident about that is very important in implanting young children. And there are other techniques to providing more light when you're doing your facial recess. For example, in infants, drilling superiorly in the antrum and really exposing not just the incus, but also exposing the malleus may seem excessive. However, that provides more light coming down into the facial recess area, which then can help you when you're looking for your round window. And then, I was trained doing drilling wells, and I'll talk a little bit more about this, but avoiding things that depress the dura are important in young infants. And we'll go into that a little bit more. So let's talk about some of the surgical challenges in cochlear implantation. And this is applicable to both adults and infants. This is where I'm going to bring up things that I think are actually known to be historical assumptions. And then I will present to you the most up-to-date evidence so that you can decide, is this true? Or is this the way it's done and we should maybe try a different way or update the way we do this? So historically, we've been taught, and I've been trained this way too, that perimodiolar implants, so implants that are pre-curved, have better hearing results. I've been trained and we've historically assumed that lateral wall implants, straight electrodes, are atraumatic and they have better hearing results, better hearing preservation, pardon me. And perimodiolar electrodes have more translocations. It's also been assumed historically that a cochleostomy is superior to a round window, and that's how I train. And I really, this portion of the talk, I really am dedicating to our residents, so because I think these are things that are important to talk about, and not just assume that the way that you're attending that day is doing the surgery is the only way to do it, or is the best way to do it, and to really know what other ways are there to do things, and what's the evidence, what is the most up-to-date evidence. So we'll talk about what's transpired in the last year with regards to these different topics. So a little bit of background, a lateral wall electrode. So this is a picture of a cochlea temporal bone. And I don't know if you can see my arrow here, but it's a little dark, but this is a lateral wall, an old lateral wall electrode. And it's known to have an atraumatic insertion. So when I say lateral wall electrode, imagine a cochlear device that's a 422 or a 522 or now a 622. It's a pretty atraumatic insertion. You can see an intact basilar membrane. You can see the osseous spiral lamina is intact, and you can see that the placement is good. A perimodiolar electrode, which is curved, you can see coming through here, has historically been known to have great outcomes. But why is it possible that it's not always that case? And that is because, and I thought this was a very helpful picture for me to understand this as a resident, and I want our residents to see it as well. Every cochlea is obviously not going to have the same anatomy, and every electrode is not going to exactly fit the curvature of the modiolus. So you can see it's nicely on the left here, nicely hugging this basal turn. However, on the right side of the screen, you can see that there's a little distance between the electrode, pardon me, I was clicking here, trying to show you here, you can see the arrow, the electrode and the modiolus. And this distance means that now you have to increase the amount of stimulation here to do the same, to get the same output. And when you increase the stimulation, you may be stimulating a wide area. So you're sort of reducing the precision of what you're doing for that electrode. So that's basically the overview of how these electrodes are different and why there could be some variability, and this perimodiolar isn't the absolute best. We'll see what the data shows. So next I want to talk about the historical assumption of round window and cochleostomy being better and historically better and the age-old way of doing it and the gold standard. I want you to think about the anatomy of the patient first. So on the left here, you can see a nicely visible round window membrane. You can see almost the entire annulus. And on the right here, you can see that the round window membrane is greater than 45 degrees away from you. And it's the position of this that really should guide you to decide whether you want to do a cochleostomy or use this round window membrane for your electrode insertion. Not necessarily a gold standard or a way you always do it, but think about the patient's anatomy and think about whether you can effectively do your procedure. Why does that matter? This is another really important point to learn, especially for the residents, so they can understand why we do what we do. It's all about the vector of insertion. And so 90 degrees means that the round window is completely facing away from you and is going to be difficult to see and difficult to have a good placement insertion of the electrode, because you can't really see where you're going, and you're more likely to deflect off the wall, cause trauma, and you may not be able to completely get a full insertion. So when you have a greater than 45, these are favorable, but when you have a greater than 45 degree angle, then the round window is likely not the best way to approach it. And there's one other thing that's important to understand, is that inside there is a bony crest called the crista fenestra cochlearis. This can deflect your electrode if you don't have good visualization and you're trying to use a round window to place it. And so that's really important to learn. And it's something that's not mentioned very often until you are cochlear implant surgeon and learning the different anatomical challenges. So if you run into that, you will end up with an electrode that's not making it through the basal turn. And there's been lots of studies on this anatomical detail. And I want to highlight it because through all these temporal bone studies, it's been found to occlude up to 30% of your visualization. So adequate bony removal is really important. Knowing your anatomy is really important, and knowing when to use certain approaches is really important. So again, round window versus cochleostomy, is there one that's better or the other? I'm not going to say that there's one necessarily better than the other. Round window, again, for the residents to review, is when you put the electrode through the round window membrane, and a cochleostomy is when you drill a bony opening. There's differences in how you perform this surgically. When I perform a cochlear implant through the round window, I incise the membrane, I don't peel it off, and then try not to cause, after you incise the membrane, you try not to drill anymore, not to allow any blood in there, not to suction any of the fluid, and to place the electrode slowly over the course of 1 minute through the round window membrane with an anterior medial inferior vector. A cochleostomy is when you drill a bony opening into the scala tympani. You can use your round window as a guide. You go anterior and inferior to it. You can drill the bone and blue line and then find where to enter. It does lead to more bony debris, blood, and potentially trauma. However, a full insertion, adequate insertion is important, and so it has a role, a very good role. And how I like to discuss this is something called adaptive cochleostomy. The point is that one method does not fit all. Your approach to the cochlear implant should be specific to the patient's anatomy and to the electrode that you're going to use. So a good way to approach this is to say adaptive cochleostomy means if you're going to use a perimodiolar electrode, you'll be using a bony cochleostomy. That's the most effective way to place that. And a lateral wall electrode, a straight, slim electrode, can be placed through the round window membrane, but you need a favorable angle of the membrane so that you can insert the electrode appropriately. If you don't have that angle, that's when you make the decision to make the bony cochleostomy. This here happens about 10 to 13% of the time. So a Trilogic best practice from 2015, actually their conclusion was that lateral wall was superior to perimodiolar electrode and that round window was superior to cochleostomy approach. And the reason is, the summary of all of this is essentially they found that they had the most amount of full insertions of the electrode with a lateral wall round window approach. I was actually surprised to read that perimodiolar electrodes did not achieve full insertion a significant number of the time. And as we know, a full insertion is ideal for hearing outcomes for our patients. So now I want to talk about new and recent data in cochlear implantation. And this, again, is a lot of data on adult cochlear implants. However, these concepts are important in how we manage adult and pediatric cochlear implants. And this is all from the past 6 to 8 months. Now, one thing to know when we're interpreting data about cochlear implants is that it seems that each sort of study is a center that uses a certain device or a certain manufacturer, essentially. And so this study from 2019, Dowell, their conclusion was that lateral wall electrodes had better hearing preservation, which is not novel. Perimodiolar had been doing well in the past, but they had equivalent speech perception to perimodiolar, so something to consider. That's for cochlear devices. Study from Brown this year that was just published, they had equivalent results with hearing preservation, lateral wall and perimodiolar electrodes. And then last but not least, when using Med-L devices, they had better results with lateral wall than than using lateral wall cochlear devices. So all in all, there's a lot of variability. It seems that lateral, in many studies, lateral wall and perimodiolar are equivalent. My point here is just to say that the historical assumption that perimodiolar is better is not existent anymore, and we should really be thinking about how some of these things are changing with how devices are changing. And then briefly mentioning hearing preservation, they saw a big difference in the type of device that was used. And it was interesting because it wasn't necessarily that the shorter, smaller Cochlear 522 was better. And so the authors, when asked off record, their conclusion was actually, it's due to more of a cochlear microenvironment. That may be more important than insertion trauma and the length and the size of the electrode. And so there's a lot that we don't understand about these, hearing preservation and having outcomes in terms of trauma. And then last but not least, the perimodiolar electrodes in terms of translocation still stands as having the increased amount of translocation compared to lateral wall. Another update in the world of cochlear implant and pediatric cochlear implant is the new electrodes, such as the 632 and the 532 from Cochlear. I don't know, I know many of us are not using these very often. I know we have maybe once or twice. And I just wanted to bring this up and talk a little bit about it. And maybe at the end, you can give me some of your thoughts on this. So these electrodes are atraumatic. They're smaller than the old perimodiolar electrodes. It's essentially trying to make a hybrid of everything, the sort of atraumatic and morphology of the lateral wall, but having the curvature of perimodiolar. And then the best part, I think the best part for me, because I was trained on the 412, is that stylet, it can be reloaded. And as you all remember, the painful part of the 412 and 512 is that once the stylet is out, it can't be rethreaded. And so you really just get one chance for placement. Here you can reload it and attempt again. The thing that's not advantageous and why many of us are not excited to use this is that you don't get much feedback, tactile feedback when placing it. So you don't really know if you have resistance. Although one can say that by the time you feel resistance anyway, you've already caused trauma. And so does that really matter? I'm not sure. But it is also requires it has a large sheath, so it's difficult to see. And in our pediatric cochlear implants where we have limited visibility, small recess, it can be less favorable to use. The results that are so exciting about this and why Cochlear is so excited, we should take with caution. It's mostly done at one center. It really relies on doing imaging afterwards and using the proprietary system that they have to turn off and on certain electrodes that are in anatomically advantageous positions. And this can be impacting the results. So we should really understand that. And I say it's not repeatable, though I hear that they would, if you send them imaging from your own center, they would look at it and give a recommendation to our audiologist about what electrode needs to be adjusted. So, and again, large sheath and large anatomy there for the electrode. So those are some of the updates on electrodes and some of the historical assumptions about anatomy, about cochleostomy, about electrodes, and hopefully that helps with clarifying that, especially for the residents who may be more subjected to some of the historical information. So let's continue talking about controversies and talking about what's new and the new updates in pediatric cochlear implantation. I think this is really important to talk about because I think this applies to our patients on the pediatric side, more so than the adult side, but even the adult side as well. So the cochlear implant incision has evolved, become much and much smaller. And then the way that we secure our receiver stimulator has evolved also. I was trained with always drilling a well. And and checking and making sure that the appropriate depth of the well has been drilled. And the receiver stimulator morphology has evolved over the years. You can see on the picture here on the right, the old receiver stimulator was not as wide, but was thicker. And now the lower profile ones have a bigger width. So what we need to think about is for that same implant, we now need 3.4 times more area to drill a well. And when you're talking about young infants, as we get younger and younger, as we learn more and more about optimal time for implantation, we should really think about if this is a reasonable option. And in infants, the skull thickness may not allow for, for having a well that has enough depth to really seat it. And so if you drill a well that isn't really going to seat your implant and put the receiver stimulator there, it could move. And also, if you're going to drill an appropriate well in a young infant, you're going to cause a lot of edema, potentially bleeding. You have to undermine, again, a significantly more surface area to be able to fit this new low profile but wider receiver stimulator. So this was something that I thought was very interesting, and this is something that I changed the way that I secured the receiver stimulator. I also learned about rare but reported complications of drilling a well, such as dural tear, which is very common. You've probably seen it yourself, a CSF leak, then things that I had not seen in my training or in recently ever, such as a subdural hematoma. I hadn't even known previously that this was possible if you're drilling a well, but it is. Epidural hematoma, and even unfortunately a cerebral infarct. These are all rare but devastating complications of drilling a well, which then makes us ask the question, what is the best way to manage our patients? And so the next question that comes to mind logically is the gold standard, the well technique, still the best option for our pediatric patients? Or should we consider a different technique? The pocket technique has been well described, well described actually in a paper that was 11 years ago. And the advantages are such: it's more efficient, you have less operative time in infants, the incision is smaller, you don't have to undermine as much tissue. It takes advantage of the whole point of this new receiver stimulator being thinner and lower profile, is that you can secure it under a periosteal tight muscular pocket. And then less edema. I mean, they truly have less edema because you're not drilling, causing bleeding and retracting with an Army Navy under there to really visualize that whole area that you're drilling. And so the time to activation in our patients is 2 weeks, is what we do here at our Cochlear Implant Center. But it can be as soon as 2 days, and it's been reported that way, which is very different from how I trained, which was well and at least 1 month for activation because of the amount of edema. When we're talking about infants and barriers to care and challenges in not just diagnosis, but actual time to implantation, and we're talking about time being speech outcomes, it makes a difference whether they're waiting a month or we can activate them sooner. But less edema and less pain is really, really important. Not having those devastating complications being on the table is important for me. This is what changed my practice. And also, I have colleagues that call me and ask me about did I switch from the Iowa way of doing the well to the pocket technique. And really what another thing that really changed my mind is that one of my colleagues did the well technique in a very, very young infant. And all in all, in a bilateral case, it was very difficult to see, difficult to secure, lots of bleeding, added about 2 hours to the case. And so really think about the surgical time when we're talking about these patients. And this is a study showing that implant migration was equivalent in the two groups. So that is, again, another reason why we should consider the pocket technique. So talking about updates and in cochlear implantation, now I want to switch gears and talk about single-sided deafness. and talk about cochlear implantation for single-sided deafness. This is probably the biggest question that we get asked, and we ask ourselves as well. So the FDA approved cochlear implants for single-sided deafness as of last fall, and in children over age 5. And I want to take a step back and talk about the historical perspective on single-sided deafness. So why is this happening now? What do we know? How were we managing these patients before is the biggest question I had. So historically, single-sided deafness has not been considered important enough. And I don't know why, because this is not a small problem. If you're conservative, you can make an estimate that there's 2 to 5 children in 1,000 children and teenagers that have single-sided deafness, and they can be identified late. For example, I had a patient come to clinic. I had a 6-year-old patient who was in kindergarten. And kindergarten is a typical age when children are really aware of themselves and their bodies. And he had not done any hearing screening at school. He had simply asked his mother, "Mom, what ear do you hear from? Because I hear from my left." Everyone only hears from one of their ears, right? And so that's how they identified that this child was deaf in one ear. And he's in a classroom environment that is not accommodated to any of this. And so this can really be identified late and cause significant detriment to our patients and their outcomes. Kids that have unilateral hearing loss have a big impact, and I don't think this is something we should ignore. Because previously, we didn't have a lot of great evidence or options and what were we going to do for these kids? It's almost that we didn't really pay enough attention to it. These kids are half as likely to be referred for hearing testing. They're missed. They have poor spoken language performance. They have cortical responses that are different than bilateral hearing kids. I mean, they don't have the same amount of development neurologically that happens in bilateral hearing kids. So I'll touch on that a little bit more. I mean, for true binaural hearing, you need that development. And then when compared with their siblings with normal hearing, they have lower verbal IQ scores, lower language scores. The other thing that I thought was really significant is about 30% higher chance of repeating a grade in these children. So the old notion that, they'll be fine, we don't have to do anything, is something we should really question, and we should, that's a challenge that we face, and we should provide the best possible care for our patients, which may not be doing nothing anymore. So a little summary of binaural hearing. I'm going to get a little bit more detail into this. It's advantageous to all individuals. It doesn't matter if you're normal hearing, you're a hearing aid user, you have a cochlear implant, we all use this, and this is very important. It helps us dealing with noise. It helps us localize. But the thing I really want to focus on is in children, they have passive learning. So it's essentially incidental learning that happens in children. They are learning through their sound field. So imagine a baby who's learning from his or her environment. If you remove half of that environment, that really decreases the amount of learning by decreasing 50% of their sound field. The mechanisms, and this is a lot of detail, but this is something we've all sort of learned about different aspects of this. I want to remind you about binaural hearing mechanisms so that you can see how patients that could get a cochlear implant on one side, how this is helping them. So sounds are louder, that's summation, if you are hearing from both ears. And the sound, I'm sorry, if you're sending a chat question, I'm not going to be able to see it as I'm sharing my screen, but I'll get to it at the very end. Binaural summation is that sounds are louder. So you get about a 3 dB increase in sound hearing benefit by hearing from 2 ears. On the other hand, squelch is taking noise and reducing that signal, and that's about a 1 dB advantage. Localization is the thing that we talk about a lot. So localization is improved with binaural hearing, whether it's because of the arrival and time difference or the loudness difference. And that varies based on the frequency of the sound. That's because of the size of the period of the sound wave. But overall, it's that you have a 20% improvement in speech recognition. And so that's what these pictures are showing in terms of noise and sound. And so single-sided deafness in children. Basically, the summary of the slide is that we know there's all these effects. We know there's all these mechanisms. that help with localization and with speech perception. Should we do something or should we do nothing? And when you are using important to remind us, when we're using a cross or a Baha, when we have a child who has single-sided deafness and we're giving them a Baha or a cross, we are not giving them localization. We are just making that sound louder that's going to the other ear. So they may be able to understand it better, but they will not be able to localize the sound. And their brain is not binaurally processing this information. So cortically, they have the same development as if they had single-sided deafness. So that's a big difference. Now, cochlear implants in single-sided deafness, but in congenital single-sided deafness is really important to think about. So in this study, so first of all, cochlear implant is the only way to really restore binaural hearing. And this is one of the largest studies, and it's from 2017. Prior to this, there were studies with maybe 3 children or 4 children. Here in 21 children with single-sided deafness, they were implanted between the ages of 10 months and 11 years. And they showed improvements in noise and localization. I will show you a piece of information that explains how. And fortunately, they also found that there really was no difference in outcome if they were implanted before age 6 or after. So there wasn't, at least with this information that we have, the newest information that we have, there wasn't a difference in the 10-month-old versus the older children. So how did they know that getting a cochlear implant in a deaf ear in a congenitally deaf child was going to help that child? Well, they basically essentially tested these children in noise with their implant and without. And here you can see, so on the y-axis of this chart, lower is better. That means that you can handle noise better. And you can see, I have this picture here on the left to show the different hearing environments and why they matter. The red dot here is when the sound and noise are coming from 0 azimuth. And the other 2 conditions here are if noise is coming from the deaf ear and if noise is coming from the hearing ear and sound is coming from the other side. So obviously the best performance was if noise was coming from the implant side, the deaf ear, the previously deaf ear, the SSD ear, and sound was coming from the acoustic hearing ear. But in all conditions, the patients performed better with the cochlear implant than without, is the point of this. Another point to be made is that a study by Sharon Cushing and Blake Papson, they saw cortical organization be restored by cochlear implants in children with single-sided deafness. So having that part of the brain be activated is necessary for true binaural hearing. And they actually saw when children have single-sided deafness, obviously they don't have any activation there, but they were able to change that over time in these children. Now, it would be unfair to present all of the positive information about SSD and cochlear implants and not talk about any, disadvantages or anything we should think about. In this study of 21 children, ultimately about 14% of these children became non-users, which is relatively a low number, but again, it's something to think about. And there are other studies that have had some disadvantages as well, smaller studies with an N of perhaps 3, where the patients had limited benefit and some had limited benefit with localization. However, I want to, remind you that the biggest study that we've had so far, the patients did well. And so the next point I want to make is that, well, why were some of these patients that single-sided deafness really wanted to get implanted? This isn't something that's necessary for speech and language. Why did they ultimately become non-users? And when they asked these parents about, why did you ultimately stop using the cochlear implant? One big theme that arose was that while they were happy with the implant, they did not like the stigma that it brought upon their child. And it's different for the single-sided deafness kids because they don't have to wear an implant to be able to develop speech and to be able to communicate. It's essentially a choice. It gives them better localization, better binaural hearing, but it's not necessary. And so it brings upon that thought that, well, the patient and the family didn't like the stigma of, being identified with hearing loss. Now that they're wearing a cochlear implant, it's visible. It was taking an invisible disability, hearing loss is an invisible disability, and now making it visible. And so I think that's another big barrier to care, is that hearing loss is an invisible disability, and sometimes, it does not get addressed appropriately. Now, some of our patients, speaking of disability, have a visible disability. And I want to bring this up because this is unique to our pediatric patients. A group of patients referred to as deaf plus. That means that they have hearing loss and another disability. So these patients could have, Down syndrome or autism or other diagnoses. That's a third or more of our patient population with sensory neural hearing loss. And this plays a big role in how we as pediatric otologists manage and evaluate these patients. And we really evaluate the patient as a whole, behaviorally, look at all of the different aspects of their care and their health, and see what realistic outcomes there are for this patient. And also there's a big variation in this subgroup. When I say a patient with hearing loss and autism, I mean, autism is a huge spectrum from very mild to very severe. And so it's very difficult to study this group because they have such a big variation. Nonetheless, there have been studies on this group asking the question, should we be implanting children, for example, that have significant cognitive delay? And CCS California specifically says the primary goal of cochlear implant is to develop the development or enhancement of auditory oral communication. But is that the only merit of a cochlear implant? And if so, then we really shouldn't be implanting these kids. Or is it a question of quality of life and sound awareness and speech perception? Even some children that actually end up ultimately developing open set speech, even though we did not anticipate that. There are some studies of this deaf plus population of kids, and they're hard to study. You're not going to get detailed speech scores and localization and all these things because, unfortunately, this population is challenging to study from the get-go. But they were able to ask parents about their speech perception of the children, and parents' perspectives were very positive. And this is really where having a good pediatric cochlear implant team comes in, to make these difficult decisions about these patients, to talk about them from the audiologic perspective, from a perspective of our speech pathologist, from the perspective of their other medical conditions neurologically. What is their prognosis? I mean, what are realistic outcomes for these patients? So this is really where I'm very grateful to have an excellent multidisciplinary cochlear implant team, where we talk about these patients, and we meet twice a month on Thursday mornings and discuss all of our patients multiple times throughout the process. And we all weigh in on our experience, or our experiential recommendations, things specific to that patient, and come up with a consensus, a recommendation that we can then give to that family. This is what we recommend as a team. So our cochlear implant team, cochlear implant surgeons, our audiologist, speech pathologist, so we have a robust team, and we're very, very, very lucky to be working together. Here's our Stanford Pediatric Otology team. And last but not least, our Stanford Ear Institute team, the adult side that we collaborate with as well, on the Stanford Ear Institute side. So we're almost out of time, but I want to leave you with one last thought, and that is, as you know, I'm interested in wellness. I'm the representative for otolaryngology at the Wellness Council. And I want you to think about, so today I talked about pediatric cochlear implants and pediatric hearing loss, which is my passion, but I want you all to think about your area of expertise. We all are so, we have such a small niche of something that we're really, really good at. And we are experts in this. We are passionate about it. We help our patients breathe. We help our patients swallow, we help our patients hear, we do these critical things for our patients. And we often don't think about that, but I urge you to use this moment, in time where there's pandemic and discrimination and all these things happening in the world, to really think about your expertise and your purpose and use that to build resilience. So for me, I shared a story about the first day when we came back from COVID, when we weren't operating. The first day we came back was April 27th, and the first surgery that I did was a bilateral cochlear implant on a 2.5-year-old who was delayed identification. And we do cochlear implant surgeries, and we do whatever surgery you do in your specific niche, and we come to think of it as routine. But when we're not able to do something, that month where we couldn't implant children was difficult. We knew these children needed to hear and develop speech and language, and it really reminded me of how purposeful our job is. And I hope that you all can think about something that you do and realize your purpose. I'll take questions.
Yoram, that was a great talk. Couple of thoughts or plug. First, I want to give our team a plug, actually. We were one of the centers that provided data for that, for the FDA trial, or the FDA to get the reduce the age of cochlear implantation. And Kay gave a great talk at ACIA on the surgical implications of state and the safety in that regard. So it's just a little plug for our group. It was we played a big role in that, and we were kind of happy to do so. So thank you, Kay, for
That's right. Kay, are you there?
Yeah, I'm here. Yeah, that was a great talk. I really enjoyed the talk, and I thought you raised a bunch of topics that stimulated thought. I do have a comment about this round window versus cochleostomy debate, which I think is going to be a forever debate that will never be ended. When you presented the thing about the angle of the round window helping to determine things, I would say that you can actually, if you have an unfavorable insertion angle through the round window, by drilling off the appropriate ledge of the round window, you can actually change the angle to a favorable angle. So a round window approach person would say you're not forced to have an unfavorable angle if you drill. But then the cochleostomy surgeons will say, well, if you're drilling all the ledge off the round window, you're basically, that's the biggest advantage of the round window was atraumatic.
Not to cause trauma, right?
On the cochlea, and if you drill the round window ledge, that's just like drilling the cochleostomy. So you've negated your advantage. I don't know that there's any strong data that clearly shows that one approach is better than the other approach. So I think that this will forever be debated.
Okay, maybe I'd like to weigh in also as a round window guy. This is Nick. I found that drilling the round window niche, at least in the adult patients and in most kids, is really really does allow round window insertions in just about all patients. I would say that the reason that I sometimes will use a cochleostomy is really because of the position of the facial nerve relative to the round window, rather than the angle of the round window itself. But I think, Aram, you brought up some really great points about cochlear anatomy and how we need to be able to, adapt our approach depending on what we are presented with our patients. So that was a great talk. So thank you.
Thank you.
Yeah, that was a real good talk, Aram. I agree with Nick also. Most of these abnormal angles can be converted to a more favorable angle. And I think drilling that niche is really not that traumatic because you're not getting into the cochlea. There's no blood and dust inside the cochlea. It's, if anything, there's very minimal noise exposure, and that probably is irrelevant in these patients. I do it very often, and our patients have had really excellent results with both hearing preservation as well as insertion. So I think the round window is possible in most patients.
I would agree with that. I just think it's important also for our residents. They may go on to other institutions, and I want them to have a fair evaluation of different approaches. For me, coming from a cochleostomy institution, doing all round window was different, but I really thought about it, and after looking into it, thought it is doable and it has good outcomes. So
yeah, we all trained on cochleostomy for decades and years, and so the round window is, I think, more easier and better and more superior in my opinion.
Yeah, I think there are really good things about cochleostomy as well, but you have to be able to drill down to the endosteum and not go through the endosteum, and that can be very difficult. So I mean, I think if we were able to shave down the otic capsule so that we had the endosteum and could make an incision into the cochlea without actually opening the cochlea with a drill, I think that there would be some real advantage of that from a sort of a mechanical or anatomic perspective, but that's a very difficult thing to do.
any other questions?
Just a comment. I love that you brought up the perimodiolar versus the lateral wall component. I mean, because that's been an ongoing debate on this for a long time. I actually published a paper on that, this about 12 years ago in that area. But when I read the current literature on it, it really seems to come back to, the risk for translocation goes up when you have a perimodiolar array. If you can avoid that scenario, then there's a lot of theoretical advantages to a perimodiolar array. And you're right, there was actually a paper published that came out pretty strongly in favor of perimodiolar arrays over matched patients with the lateral wall. But as you rightly point out, it's one center at this point, and so it really hasn't been replicated outside of that. So I think that's really that's another one of these eternal questions, as you mentioned, with the with
But
round
it's
window
good
versus.
to talk about and not have our historical assumptions carry on.
Oh yeah, there's a lot of great theoretical reasons for perimodiolar array. It just hasn't consistently borne itself out. The one thing that shows up again and again is the impedance levels tend to be a little lower with perimodiolar arrays, and you tend to get a little bit better battery life. And after that, in terms of spatial spread of excitation,
Because you make it monopolar.
Yeah, everybody's monopolar at this point. So those are really kind of some of the key issues. And then after that, with regard to the spatial spread of excitation, that's just varied a little bit. And I think that probably has to do with just the likelihood goes up of a translocation if you're with a perimodiolar array.
Hey, Urim, I had a question about one of your statistics that you presented on your earlier slides that surprised me. You presented a statistic, only 36% of infants that could benefit from cochlear implants get them. And that's a lot lower than I would have guessed. So I'm trying to figure out, where did you find that statistic? Because that statistic surprised me.
From a talk by Craig Buckman. From one of his papers. And it was for adults cited, 6 to 8% get cochlear implants of those that are candidates.
I see.
Any other questions? Thank you everyone for your attention, and thank you for attending. Appreciate your support.
Thank you, Ram. I learned a great deal. That's the highest compliment I can give. It was a terrific talk. Thank you.
Thank you. Good night, everybody.